Now, there are three conditions which are grouped under the non-leukemic myeloproliferative disorders. And these disorders are polycythemia rubra vera, essential thrombocytemia, and the last one there is idiopathic myelofibrosis. So clonal disorder, which results in proliferation of the cells, either the red cells, the platelets, or clonal deposition of fibrous connective tissue in the bone marrow, and that is idiopathic myelofibrosis. Do I put this off? So, I said it is a clonal disorder. So, because of a molecular abnormality, there is a clonal proliferation of cells that will give rise to increased number of erythrocytes, platelets, granulocytes, and even monocytes. And there is a variable tendency of these disorders to transform into acute myeloid leukemia. So there is a variable tendency of these disorders to end up as acute myeloid leukemia. These are not curable diseases unless we do a stem cell transplant. They are not curable, and the treatment is basically symptomatic. We use medications and other modes of treatment, which I shall mention, to manage these patients. So the first one is polycythemia rubra vera, also known as primary polycythemia. When we talk about polycythemia, we are talking about increased number of red cells in circulation, and there are other causes of increase in red cells in circulation, and those are grouped under secondary polycythemia. When we talk about polycythemia rubra vera, that is primary polycythemia. That's a problem in the bone marrow. It's a hematological condition. It's a clonal disorder. So this is a chronic disorder, and it's due to a clonal expansion of a multipotent stem cell. And this the stem cell will differentiate and give rise to increased number of red cells. So the lineage which predominates in this clonal disorder is giving rise to a lot of red cells. We get erythroid hyperplasia. And when we have a lot of red cells in circulation, the viscosity of the blood is increased. So most of the symptoms are related to this increased viscosity that we see in these patients. So when the red cell count is increased above the normal, then the packed cell volume will also be increased. And these are two important parameters when we are evaluating and managing patients with polycythemia rubra vera. The red cell count, hemoglobin, and the hematocrit are the three important parameters that we look at in these patients. So the clinical features, patients are usually between the age of 40 and 70 years. Sometimes we see younger patients, and others are just discovered incidentally when they present for a routine checkup. Maybe it's due to a routine medical examination for admission into college, or for jobs or for insurance purposes. And when we do the blood counts, we find that the hemoglobin levels are high, the red cell count is increased, and the hematocrit or packed cell volume is also increased. And the symptoms, because we have a lot of red cells in circulation, so the blood becomes very thick and viscous. So the blood flow becomes sluggish to various organs. So when it's when we have low circulation to the brain, the patients complain of headache. There is weakness. A unique feature is generalized pruritus, dizziness, sweating, visual disturbances because of involvement and engorgement of the retinal veins. And because this is a proliferative condition, the patients will have weight loss, significant weight loss, more than 10% of baseline. And that's because there is increased metabolism in these patients. So headaches, weakness, weight loss with night sweats as well. They also have dyspnea on exertion, and some of them will have thrombotic episodes because the blood is very thick. The flow is sluggish, especially in the veins of the lower limbs. They may present with deep vein thrombosis, clots within the venous system, the leg, the lower limb venous system, or even the mesenteric venous system can also get involved. The splenic vasculature can get involved, and the portal and hepatic veins can also get sluggish blood flow, resulting in clots within that vasculature. So although venous thrombosis, that's clots within the veins, is more common, we can also have clots within the arteries. So if you get a blood clot in the artery, the distal organs are going to be starved of oxygen, and we get infarcts. So we may have stroke, cerebral infarcts, or if the myocardial is involved, if the coronary arteries get blocked, then we get myocardial infarction or cardiac infarcts. So those are some of the serious features that we see in patients with polycythemia. Peripheral gangrene, if the blood supply to the lower limbs, especially the feet, are compromised because of sluggish blood flow and clots, we may get peripheral gangrene. Peptic ulcers, if there is involvement of the gastric vasculature. And because of the high cell turnover, there is a high cell turnover, so there is increased nucleic acid breakdown, and we get high levels of uric acid, and the patients may present with gout due to increased uric acid production as a consequence of the high metabolic rate. A few of the patients will present with bleeding. That's because the platelets may not be functional. The platelet aggregation gets affected, and we may have bleeding in some of these patients. When we look at them, it's very, when you look at the patients, if you look at the skin, especially those who are of Caucasian descent, I mean, the face is so flushed, it looks very red. If you look at the mucous membranes, if you look at the palms, they're of a florid dusky red color, and that tells you that there is polycythemia that we see in these patients. When you look at the mucous membranes, if you look at the conjunctiva vessels are congested, very prominent and red. Look at the eyes. Then we have enlargement of the spleen in about 70% of the patients, and the liver in about 50% of the patients. Generally, when we have a myeloproliferative disorder, splenic enlargement and hepatomegaly are some of the findings on abdominal examination. So when we do a blood count, we look at the hemoglobin levels. The hemoglobin levels are elevated, usually in the range of 18 to 24. and the packed cell volume is raised. It's more than 47 in females and 52 in males. We can use specialized tests to determine the red cell mass and volume, but these are not readily available. Sometimes we need to use this studies, radiolabel studies, and see the distribution of red cells and determine the red cell mass and volume, which is done by the Department of Nuclear Medicine. By using radio-labeled red cells, we are able to estimate the red cell mass and volume. Now,
recording in progress.
Cause a significant demand for iron, and as a consequence of that, we may have an accompanying iron deficiency. Now, as part of the process of red cell maturation, we may have collateral maturation, increased maturation of the white blood cells. So there may be an accompanying neutrophil leukocytosis with a left shift. And when we do a biochemical test called neutrophil alkaline phosphatase, this score is usually normal or mildly raised. One of the unique features in myeloproliferative disorders is that there is an accompanying increase in the basophil count. We call that basophilia. So that's another useful collateral marker that we sometimes allude to when we are dealing with myeloproliferative disorders. And as I mentioned earlier, there is significant overlap in the myeloproliferative neoplasms. So there may also be an increase in the platelets in more than 50% of the patients with polycythemia rubra vera. As I mentioned, the blood viscosity is increased. There are some lab tests that we use to determine blood viscosity, but these are not routinely used in our laboratories. And because of the high turnover of red cells, the erythropoietin levels are usually normal or slightly reduced. That helps us to differentiate primary from secondary polycythemia. In secondary polycythemia, usually due to lung diseases, hypoxia, or high altitude training, because of low oxygen levels, there is an increase in erythropoietin in secondary polycythemia. But in primary polycythemia or polycythemia rubra vera, the plasma erythropoietin levels or serum erythropoietin levels rather are reduced or normal. So other laboratory findings, as I mentioned, that this is a high cell turnover disease. So the uric acid levels will go up. So there is hyperuricemia. And this is a clonal disorder. So there have been a number of genetic abnormalities which have been identified, especially those of chromosome 8, 9, and 20. And a couple of years ago, there was another mutation that was identified, and that is known as the JAK2 V617F mutation. So there is a mutation in the JAK gene, and that results in increased cell proliferation of the pluripotent stem cells. So this is just a diagram showing the effects of the JAK2 mutation. The JAK2 the JAK2 moiety is present on the erythropoietin receptor, and when erythropoietin logs on to its receptor, there is downstream activation of various kinases, which result in cell growth, the cell cycle progression and growth, and it also has anti-apoptotic activity. When these kinases are activated, we get anti-apoptosis, which means the cells are going to survive longer. Now, when we have this mutation known as the JAK2 V617F mutation, even in the absence of the erythropoietin molecule, the receptors continue to be activated, and we get downstream cell cycle progression, growth, and these cells are going to live long because of the derangement of the apoptotic pathway. So when we say anti-apoptosis, it means the cells are not dying, they are living long, they are proliferating. So all this results in an increased number of circulating erythrocytes. The same mutations are seen in the other two conditions that I will be talking about shortly. So basically, the ideal management of these patients is to reduce the red cell count and improve viscosity. And the fastest way of doing it is by doing a Venisection. Venisection means removal of blood. So we can remove 1 unit of blood or at any sitting. And 1 unit of blood will bring the hemoglobin levels down by 1 gram per deciliter, or it will bring the hematocrit down by 3. So we are able to estimate how many units of blood we would like to remove, so that the hematocrit and the hemoglobin levels will come back to the normal range. And many patients are quite well managed with Venisection. They're comfortable, and we also encourage them to take a lot of fluids. Sometimes we also have to give them intravenous fluids so that the blood becomes less viscous and the flow of blood is smooth throughout the body. Now, unfortunately, some patients will require very frequent Venisection. And in this situation, then we use drugs like hydroxyurea, which will reduce the proliferation of the red cells in the bone marrow. We can also use radioactive phosphorus, but this is not being used these days. And now we have inhibitors towards the JAK2 mutation. We call those the JAK2 inhibitors. They are now available for treating patients with myeloproliferative disorders. So we've looked at at polycythemia rubra vera, which is one of the myeloproliferative disorders in which there is increased proliferation of red blood cells. And we have looked at the consequences of that proliferation, what causes that proliferation, and how to manage it. Now we'll talk about essential thrombocytemia. Now, in essential thrombocytemia, as I had alluded to earlier, it is a clonal myeloproliferative disorder. But in essential thrombocytemia, there is proliferation of megakaryocytes. There's clonal proliferation of megakaryocytes. And these megakaryocytes produce lots and lots of platelets. And we get marked thrombocytosis in these patients. Now, this is a disease that we mainly see in older patients between the age of 50 and 60. However, we may also see very occasionally younger patients with this disorder. Now, like polycythemia, in essential thrombocythemia, the viscosity of blood is also increased because you have a lot of platelets in circulation, and these platelets can aggregate and cause thrombotic manifestations. So they tend to block the arterial blood supply to various organs, and may present in a similar fashion to polycythemia rubra vera. Now, in a few of the essential thrombocytemia patients, despite the platelet count being high, they may present with bleeding manifestations. And the reason for that is that these platelets are not functional. They do not aggregate very well. And as a consequence of that, bleeding becomes a dominant clinical feature. Usually the platelet counts are more than 600. And sometimes we have platelet counts of more than 1,000. I've seen counts of 1,500, 2,000, up to 2,200 times 10 to the power 9 per liter of platelets have been seen in some of the patients. And it becomes very evident when we look at the peripheral blood film. There are some large forms of platelets. The size varies, but there's so many large forms of platelets, and it's a typical picture. When we do the bone marrow examination, we see these atypical megakaryocytes in the bone marrow. Now, like as I mentioned, for polycythemia rubra vera, as we are having proliferation of the megakaryocytes, there may be collateral proliferation of neutrophils, monocytes, and basophils. So these may also increase, and we may also have an increase in erythrocyte proliferation, resulting in increased hemoglobin levels. So there is some degree of overlap in these conditions, essential thrombocytosis and polycythemia rubra vera. And sometimes when we examine the bone marrow and we see abnormal megakaryocytes, we are able to say whether this is essential thrombocytemia or polycythemia rubra vera. As I mentioned, myeloproliferative disorders, there is a variable degree of splenic enlargement in essential thrombocytemia. So again, it's important for us to demonstrate the clonal nature of this disorder, because there are other conditions where the platelet count may also go up. Increase in platelets may also be seen in inflammatory conditions, in GIT bleeding, and then it becomes important then for us to differentiate essential thrombocytemia from secondary causes of thrombocytosis. And again, we go through all these clinical features. If you see splenomegaly, we know we are dealing with essential thrombocytemia. Again, we can do the JAK2 mutation studies, and if they are demonstrated, that helps us in making a diagnosis of essential thrombocytemia. And the last disorder in this group is myelofibrosis, idiopathic myelofibrosis, which used to be known a number of years ago as myelosclerosis or angiogenic myeloid metaplasia. These were terms that were used, but the current term that we use is idiopathic myelofibrosis, or simply just myelofibrosis. In this disorder, there is a clonal deposition of fibrous tissue in the bone marrow, and it is seen in people between the age of 40 to 70 years. And one of the key features of myelofibrosis is that there is enlargement of variable degree, usually moderate to marked enlargement. Sometimes the spleen is there in the right iliac fossa. We've talked about splenomegaly in our previous lecture, and I did mention to you myelofibrosis. There is marked enlargement of the spleen and abdominal distension, and the symptoms that are associated with an enlarged spleen that I talked about in my last lecture. In myelofibrosis, this is now a disorder in which metabolism is very high, and the patients have weight loss. They have anorexia because of the spleen pressing on the gastric region. They have fevers and night sweats. When we look at the peripheral blood, the peripheral blood film is typical. We see a leukoerythroblastic anemia with teardrop forms. We call those poikilocytes. They appear teardropped. I have some slides which I'll show you. It's like the bone marrow is crying because of increased deposition of connective tissue, fibrous material within the bone marrow stroma. And this fibrous tissue occupies the hemopoietic forming areas, and these get depleted. And as I mentioned earlier on, the spleen, being a site of extramedullary hemopoiesis, will get enlarged. So there is extramedullary hemopoiesis. The spleen becomes a site of hematopoiesis and starts producing red cells, white cells, and platelets, which also contribute to splenomegaly. Being a high cell turnover state, uric acid levels are going to be raised, and we are going to have hyperuricemia and features of gout. To make a diagnosis, if we do a bone marrow aspirate, because of a lot of fibrous connective tissue within the bone marrow, it's very difficult to aspirate the bone marrow, and we have to do a trephine biopsy. So that is a biopsy of the bone marrow to make a diagnosis. Now, this is just an overview, and we can see that we have this proliferation when it's predominantly granulocytic precursors. Then we talk about chronic myeloid leukemia and acute myeloid leukemia. Now, these three here are the red cell precursors, megakaryocytes, and the reactive fibrosis. These three are the ones that I talked about as being myeloproliferative disorders. You get polycythemia rubra vera, essential thrombocytemia, and myelofibrosis. And there is a overlap of these three conditions, and they may, I've also seen this in some patients. They're presenting as polycythemia rubra vera, and then a couple of years later, the platelets start going up, the red cells remain stagnant, and we get the features of essential thrombocytemia. There is some degree of fibrosis which also goes on in these two conditions, but the fibrosis that we see in myelofibrosis is clonal, and this all these three disorders have a variable tendency. Here I put it at 10%. They have a variable tendency to transform into acute myeloid leukemia. So 10% for myelofibrosis and 15% for polycythemia rubra vera. So a variable degree of transformation to acute myeloid leukemia. This is a classical picture of essential thrombocytosis. What we can appreciate at this power is that the number of platelets are markedly increased. You see this like sort of like appearances. We just go back. And what we see here, you see there's a variation in size of platelets. Some of these that we see here, this one, two, maybe these two are very large, giant platelets. And then we see some even larger platelets. These are large platelets. These are large platelets. These are larger platelets. Probably megakaryocytic fragments that we are seeing in circulation. We have some very large platelets here. Variation in size of the platelets. And this is a typical picture that we would see in essential thrombocytosis on the peripheral blood film examination. Now, this is a teardrop form that we see in myelofibrosis, a typical teardrop form. We may also see it in megaloblastic anemia, but it is very characteristic and very pronounced in myelofibrosis. When we see that, and if the spleen is enlarged, we have the symptoms. Our clinical examination is pointing towards a myeloproliferative disorder. At the back of our mind, we think of myelofibrosis, and then we do a bone marrow biopsy. Now, this is a leukoerythroblastic. You can see nucleated red blood cells in circulation, and there's a giant platelet there. And these are the white cells at various stages of maturation. That's the nucleated red blood cell. This is a leukoerythroblastic picture, which we see in myelofibrosis. There are a few teardrop forms which we can see. There's one there, and then we can see maybe another one here. The outstanding feature here is that there is presence of circulating nucleated red cells, and there is a left shift in the granulocytic maturation. So you have mature neutrophils, and then you have myelocytes, some circulating as well. And maybe this looks like a blast, okay? And a stab form there. So a left shift in the myeloid maturation, granulocytic maturation, leukoerythroblastic picture, and a giant platelet there that we may also see in myelofibrosis, in essential thrombocytemia as well. We may get a leukoerythroblastic picture. Now, this is the bone marrow biopsy, and what we see, we can't see any normal hemopoietic tissue. Probably some of these cells are of the myeloid series, but what we appreciate is a lot of fibrous connective tissue in the bone marrow, and this is a typical picture of myelofibrosis. And when we see this, we also do the JAK2 studies. Then there are other mutations which we can identify in myeloproliferative disorder, and we are able to make a diagnosis of myelofibrosis and treat the patient accordingly. So this is basically what basic overview of the treatment. Some of the patients we are just following up. They're asymptomatic, and we just follow them up. And once the spleen gets huge, massively enlarged, is when the symptoms will set in. Others, we start them on hydroxyurea. We need to give them blood transfusions and control pain. Sometimes we do radiation therapy and splenectomy. Splenectomy can be disastrous if the spleen is a site of extramedullary hematopoiesis. And then we have the new drugs, which are JAK2 inhibitors. The name of that drug is ruxolitinib, which we can use to control the disease in these patients. Younger patients, we can do a stem cell transplant for them and try and achieve a cure for those patients. Otherwise, these are low malignant potential disorders, and treatment is geared towards alleviating the symptoms of the patients. I think that was it, and it is basically a summary of lab tests that you would do. Of course, we would do to start off with is a total blood count, differential count, and examination of the peripheral blood film, which is very important. We would do a lab score. We can do the PCR tests for the BCR-ABL and JAK2 mutations. BCR-ABL and JAK2 I do routinely on my patients with myeloproliferative disorders. That will also help us differentiate, because sometimes chronic myeloid leukemia may present like a myeloproliferative neoplasm, and it may be difficult to differentiate at early chronic myeloid leukemia from myeloproliferative, the non-leukemic myeloproliferative disorders. Red cell mass studies I mentioned earlier, not routinely because performed, but some centers which have a department of nuclear medicine are able to do it. We would do the uric acid levels, the baseline kidney and liver function test, and of course the bone marrow biopsy becomes an important tool for diagnosis. Yeah, so I'll stop there because the the next topic is for another. If there are
Thank
any
you, Dr.
questions,
Davis.
yeah.
We can just wait for the students.
Sorry.
We can ask the
If
students
any
to type
question,
in the chat box.
any question,
Unmute.
let me go back. Yeah. I'll have to. Let me go to chat box. Okay. Let's go to the chat box. Yeah. Okay. So if anybody, I'm not seeing any questions. Are there any questions? Let me go down. Yeah. So one question here from Eugene: the role of radioactive phosphorus in the management of polycythemia. So in polycythemia rubra vera, we were using radioactive phosphorus a number of years ago for controlling the proliferation of the red cells. But this was abandoned. It's not frequently used because of the risk of acute myeloid leukemia with the use of radioactive phosphorus. But the idea of using radioactive phosphorus was to diminish the erythrocyte proliferation in these patients. So the next one, sorry, let me just see. I don't want to miss any of the questions. On Venisection, Mali. Venisection basically is removal of blood from the patient using a blood bag, similar to donating blood. I'm sure most of you must have donated blood. So when we remove 1 unit of blood from a patient using the same blood bag, we call that Venisection. And if the hematocrit is very high, say we are dealing with a patient who has a hemoglobin. I've seen patients with hemoglobin levels of 20 and above, and with hematocrits of around 70, 65 to 70. And I would like to bring the hematocrit down to below 50 as fast as possible, because having a hematocrit of 65 to 70 puts the patient at a very high risk of a stroke or thrombosis. So I would like to bring that hematocrit down. So I would like to remove a unit of blood. I can remove 1 unit every alternate days. So if I remove 1 unit of blood, the hematocrit will come down by 3. So if the patient has a hematocrit of 60 and I want to bring it down to say 50, below 50, I will have to do at least 4 venesections, which I can do alternate days. And at the same time, when I am removing the unit of blood, I can put up a peripheral line and give them IV fluids so as to further dilute and reduce the viscosity of the blood. So that is what venesection is, removal of blood. When you remove a unit of blood, you're removing the red cells, and you're trying to reduce the viscosity of the blood so that the patient does not get a stroke. So that's venesection. And then coming down again, we go down. What is a left shift? So when you have, as you are aware, we have a sequence of maturation of the white cells in the bone marrow. So we start off with the stem cell, which will differentiate into a myeloblast. The myeloblast then differentiates into a promyelocyte. Promyelocyte goes to a myelocyte, myelocyte to metamyelocyte, and then promyelocyte, myelocyte, metamyelocyte step forms, and then you have the segmented polymorphonuclear granulocytes, so segmented neutrophils. So that is the spectrum of maturation. But what you see in the blood most of the time are just mature neutrophils, yeah, segmented neutrophils. When you start seeing metamyelocytes, myelocytes, and even occasionally blasts in circulation, then that is a left shift in maturation of the myeloid series or granulocytic series. That is what a left shift means. Left shift we can also see in severe infections. But when you have a leukoerythroblastic picture, then the left shift is up to the blast stage in peripheral blood. So that's what the left shift means. What did you say is the cause of? What did you say is the cause of weight loss? Kimani wants to know the cause of weight loss in polycythemia. So as I mentioned, these are proliferative conditions. Okay, they are proliferative conditions, and they will cause an increased demand for energy from the body. So there is going to be an increased demand for energy, and then this will all come down from the breakdown of muscle from proteins. So the energy requirements from their carbohydrates may not be adequate, and in order to meet the metabolic requirements, we get breakdown of proteins, gluconeogenes. If you remember from your biochemistry days, gluconeogenesis. So we get breakdown of protein, and from the amino acids that are formed through one of the cycles, these are converted to carbohydrates. So you get breakdown of muscle, and that is why you get weight loss. The uric acid tests, why do we do? So uric acid levels are not required for diagnosis per se, but there is accompanying increase in uric acid levels, which can cause gout, and very high levels of uric acid can also damage the kidneys. So it's important to do the uric acid levels, and if they are elevated, and when we are treating them, treating these patients, sometimes the uric acid levels will also increase. So we would need to do the baseline uric acid levels, monitor them, and then give them medications to reduce the uric acid levels, like allopurinol, which is a xanthine oxidase inhibitor that helps to reduce the amount of uric acid that is formed and prevent gout and renal damage that may arise because of very high uric acid levels. Next one is the stages of idiopathic myelofibrosis. They do different stages, have different forms of treatment. Yeah. So now there is an early stage of myelofibrosis. This is more of postgraduate stuff, but there is a pre-fibrotic stage of myelofibrosis. So when we look at the pre-fibrotic stage of myelofibrosis, there may be splenomegaly, but there is no fibrosis in the bone marrow. But when we look at the megakaryocytes in pre-fibrotic myelofibrosis, then these megakaryocytes are classically abnormal, and we are able to say that this is the pre-fibrotic phase of idiopathic myelofibrosis. And in the pre-fibrotic phase, we just observe the patients. Some of them are symptomatic. The hemoglobin levels are normal. The white cells are normal. So we just follow them up. And when the spleen starts enlarging, and now because of an enlarged spleen, progressive disease, when they start developing anemia, that's the time we start treatment for these patients. From Tavan Munshi, he wants to know, why do these usually present in patients of 40? Now, you see, what happens is that, as I mentioned, these are clonal disorders. And these disorders being clonal, they are subjected to these insults, environmental insults, at a later age. So the exposure, as one grows older, many of these disorders start arising during this 4th to 7th decade, because that's when now they are susceptible to the molecular changes that are responsible for the pathogenesis of these disorders. So that's why we see them at the the fourth, fifth, and sixth decades. And as you all know, that malignancies the incidence increases with increasing age because of some of these the reasons that I've mentioned, and their susceptibility to environmental factors that start the process of the disease in these individuals. So that's the like chronic lymphocytic leukemia and others. We see them at the ages of 40 and above because this signature molecular aberrations are frequent in this age group. Very good question here, Mali. Can we donate venesected blood? No, we don't use the blood for donation because it is thought that by donating, if we donate this blood, we may transmit the risk factors that have caused erythrocytosis in these patients. So the venesected blood, unfortunately, we do not use for donation purposes, which is sad because the demand for blood transfusion is so high. It pains one to see that we have to discard the blood that we collect from these patients. Yeah, we know that the spleen is a site of extramedullary hematopoiesis. So we can use radionucleotide studies to demonstrate hemopoietic activity, and that would tell us that the spleen is a site of extramedullary hemopoiesis. Sometimes if the coagulation parameters are normal and the platelet counts are normal, you can do a splenic aspirate and you can see hemopoiesis in the splenic aspirate, which would point towards extramedullary hemopoiesis. But this is not routinely done. If you want to know for sure, then we use the radionucleotide studies to demonstrate hemopoiesis in the bone marrow. I think that's the last question. Very interesting question. Thank you. Unless there are any other questions, I will email the lecture to the class rep.
Yes,
Yeah.
Doctor, there are a few more questions.
Yeah.
Are these conditions common in our country?
Yes, they're pretty common. You will be seeing this in your practice. And as I mentioned, some of these are routinely picked up, but we are seeing these disorders fairly commonly in our population. As hematologists, as far as polycythemia and essential thrombocytemia is concerned, the main thing that we are interested in is to differentiate primary, that is the clonal disorders, from reactive conditions. That becomes one of our major tasks. We are now able to do the molecular studies, and we are able to identify these patients. And it is a common occurrence in this country. It is not that it's a rarity.
Yeah. Thank you, Doctor. Also, a few more other questions. I don't know.
Yeah.
Is a patient with white blood cell of 40 times 10 to the power 9 and 75% blast suggestive of AML?
Yes, if you see 70% blasts, so that means that their immature cells are predominating, and therefore this is pointing towards acute leukemia. You just need to know whether the blasts are myeloid or lymphoid. You can tell on morphology, or you can do specialized tests called immunophenotyping, where the lymphoid markers are different from myeloid markers, and you are able to tell whether this is acute myeloid leukemia or acute lymphoblastic leukemia. But with blasts of 70% in circulation, we are dealing with an acute leukemia, and we need to know whether it's myeloid or lymphoid. Also, you have to, as you're aware, chronic myeloid leukemia may also transform to acute myeloid leukemia. So with a high white cell count like that, and 70% blasts, and the rest 30%, if they are mature cells, and if splenomegaly is present, then one would think of a CML, which is transforming to an acute leukemia. Yeah. In chronic myeloproliferative disorders, you have more of the mature cells predominating. So you may see blasts, but they are usually less than 5%. Yep. Okay. Next question.
How does myelofibrosis end up leading to acute myeloid leukemia?
Yeah. So there may be transformation to AML. It's a myeloproliferative disorder, so it may transform. But the rate of transformation in acute, in chronic, in myelofibrosis is less than in polycythemia rubra vera and in essential thrombocytosis. Majority of these patients, because of increased requirements of transfusion and iron overload, they die of multi-organ failure rather than acute myeloid leukemia.
Yes, doctor.
Yeah. So, it's just that the pluripotent stem cell then at some point becomes, the blast will predominate and it turns into an acute myeloid leukemia.
Are there any screening techniques?
Screening for myelofibrosis?
I think so, yes.
Yeah, no, really, there are no screening tests for most of the hematological malignancies. We really don't have any screening tests for them. We just pick them up routinely and when they're symptomatic, or if we pick up an enlarged spleen during a routine examination. Doing a physical examination is very important, and you must try and do a physical examination as far as possible in all the patients who come to your clinic. And it doesn't take long to do a complete abdominal examination, and you may be able to pick up a spleen, a mildly enlarged spleen, and then you start the investigations. But as such, for many of these hematological disorders, apart from the hemoglobinopathies where we can screen for them, for the malignant hematological conditions, unlike for breast cancer and for cervical cancer and for prostate cancer, we don't really have any screening tests.
Yes, doctor. Okay.
Yeah.
I think those are all the questions.
I
don't know if you answered this one. How would one know the spleen is a site of extramedullary hematopoiesis?
I thought I answered it. We can do radionuclide studies, or we can do a fine needle aspirate if the coagulation parameters are normal and the platelet count is normal. And you would see megakaryocytes and nucleated red blood cells, and you would see myelopoiesis, all the stages of maturity, and you would know that this is extramedullary hematopoiesis. In fact, I had even suggested that we should do this as one of the diagnostic criteria for myelofibrosis, because I didn't mention to you earlier on, but there are other causes of fibrosis in the bone marrow. You could have metastatic carcinomas that go to the bone marrow. Hodgkin's disease also, that is involving the bone marrow, can cause fibrosis, and it can sometimes be difficult to differentiate that from myelofibrosis. But if you demonstrate extramedullary hematopoiesis, then you are more or less, it more or less confirms that this is myelofibrosis if you have the typical bone marrow appearances, and the JAK2 studies for mutation are positive. Plus, there are other mutational studies which I have not mentioned that can be used to arrive at a diagnosis.
Okay, thank you so much, doctor, for your time.
Good. Okay, so have a good evening. And is there any other lecture that I have?
Recording stopped.
I will have to confirm.
Yeah, I'm sorry I had to